Hi, good morning. I'm Steph and one of the Coronary Interventional Fellows at Royal Papworth Hospital. For this case, we have a 56-year-old female with a BMI of 29.5. She's had a 10-year history of microvascular angina, resulting in recurrent admissions to hospital for chest pain. In terms of a cardiac history, she's had an echocardiogram in 2023, demonstrating normal biventricular function, as well as no significant valvular dysfunction. She's had a coronary angiogram in 2018, demonstrating normal coronary arteries, and a perfusion scan demonstrating 10% LAD territorial ischemia. In terms of comorbidity, she's got type 2 diabetes, currently on metformin, and she's an ex-smoker. In terms of her medications, she's on 4 anti-anginals, so she's on ranolazine 750 milligrams BD, nicorandil 30 milligrams BD, as well as diltiazem 240 milligrams slow release. She's on a statin, so rosuvastatin 10 milligrams daily, and a single antiplatelet aspirin 75 milligrams daily. She's also on her metformin for diabetes and thyroxine for hypothyroidism. Now over to Dr. Stephen Hoole for the case.
Welcome to Royal Papworth Hospital in Cambridge, United Kingdom. My name's Stephen Hoole, I'm an interventional cardiologist, and I'm joined today by Patrick Heck, my EP colleague, to help with tricky coronary sinuses. Also got Steph, our Australian interventional fellow. Liz is our scrub nurse. Claire is our runner nurse. We've got Sophie and George, who are cardiac physiologists, and Moira doing radiography. We're just going to start with the setup that we have here in the cath lab. As you can see, we're not in our usual orientation. We're stood at the head end. We've got a specialized trolley that we've pinched from day wards, which normally serves patients' dinners. It can slide underneath the bed and it doesn't have any conflict with the image intensifier, and that's why it's pretty good to use for this case. But we've also got another draped table. We've got a pressure line, and we're going to get ultrasound guided right internal jugular access. The patient's been prepped with intravenous fluid to improve the caliber of the right internal jugular vein to make it easier to puncture. They've also been loaded with aspirin and clopidogrel prior to the procedure. They've had some small amount of sedation, but they're awake underneath the drape. So we're going to get going with ultrasound guided puncture. So just to orientate you, the black blob in the middle of the screen here, which is compressible, is the right internal jugular. To the left and posterior is the carotid artery, which we want to try and avoid. And we're just looking for a good place to puncture there. So we're going to start with some local anesthetic in the skin. And I usually make a nick to the skin because there's usually some resistance there when we want to get the bigger sheath through. There we go. We've got blood back there. Just disconnect. Try and keep everything still. Okay, so that's gone in. So now we're going to fluoro just to see where we are. Don't worry, it's waggling. It's because it's right next to the carotid, so pretty happy that that's in the vein. So we're just going to fluoro here. Be nice to see that go below the diaphragm. So next step in the procedure is to measure the pressure in the right atrium. It needs to be below 15 millimeters of mercury, and then we need to do a sinogram to assess the size of the coronary sinus.
So it's a multi-purpose catheter with a standard J-wire.
There we are in the right atrium. And you just take that out. We're going to need a flush on the manifold in a moment. So it's 1. So we're good to go ahead. We're going to give some heparin next. And she weighs 67, so we're going to give 6,000 of heparin, roughly about 100 units per kilo. Okay, now we're going to engage the sinus, hopefully, with the multi-purpose. Not in that direction, though.
LAO?
Yeah, LAO, please. So we engage the sinus in LAO 30. Patrick's going to give us a little Cook's tour of the anatomy while I try and see if I can find the coronary sinus.
So we choose the LAO view because in that view you essentially are looking on fast through the tricuspid valve as if it's in a clock face orientation. And typically in that orientation, the coronary sinus sits at around about 430, just behind the tricuspid valve on the atrial aspect. So if you come through the valve and you see ventricular ectopics, you're too far anterior, you need to come back and anti-clock the catheter towards the septum. And often as you ride over the valve, you will then engage into the coronary sinus. And once you're in it, your guide wire should be tracking up through the body of the coronary sinus. And that's what Steve's now doing.
We're just looking for it to catch. So this is just a rocking motion just to get the catheter to advance up the coronary sinus into the body of it. We want to be away from the os. I think that's pretty good there.
Happy for the guide wire to come out?
Yep. So now we're going to do a sinugram with 100% contrast. So you can see the coronary sinus is a good caliber. We'll do a QCA, although QCA can underestimate the size by about 30%. We're looking for something in the region of 7 or 8 on QCA. Obviously the device is 13 proximal, 11 millimeters distal.
Thank you.
But that's by eyeball pretty good. This lady's got anterior ischemia on a functional test, so we're going to catch the great cardiac vein. And you can see there's a valve right at the tip where the catheter is. And that would be a reasonable position to land the waist of this device. You can just see the ghosting of the middle cardiac vein coming in. This is draining the right coronary territory. We can't really see any other branches, but I think we want to be where that valve is. So we use the bony landmarks, the body of that vertebra. We can span that with the waist, basically where the tip of that catheter is. I think that would be a good position for a device. We're going to take this catheter out using an anchor wire in the coronary sinus. We've got a nice knuckle on that wire. We don't want too much of a belly on the wire. Good, so we've assessed, the pressures are fine, the anatomy is fine, so now we're going to deploy. Patrick will just go through the device preparation on the table.
So first up, we will sort out, this is the guide catheter, which is a 9-French cordis sheath, and the mother and child technique of telescoping the two catheters means that the multi-purpose catheter that we use to intubate the coronary sinus is now going to go inside the delivery catheter, which is the cordis sheath. And the two things are then going to be introduced back over the wire. This obviously has a curve on it, so you try to replicate that curve on the delivery sheath as well, just as a rough approximation, because that was going to aid it getting into the coronary sinus. Because each of these step-ups between the catheters has the potential to catch a little bit on the way in on the different valves and ridges in the coronary sinus that will impede your ability to get this catheter distally. Because what Steve now has to do is get both of these very distal beyond where we want to deliver the device. Because when the device gets delivered, these will get pulled back to deliver the device, so they have to be further on in the coronary sinus than the device will be itself. And with the various valves that get in the way, that can be a process that takes time and skill to get it round.
So you can put the TUI one-way valve on the back of this, but we do that later. It's a low pressure system, so we tend not to do it. Don't pin that, let it all come forward. We'll put the TUI one-way valve on once we've got position and we've taken the multi-purpose out.
Okay.
Good, so we've still got wire position.
I fixed your wire.
The QCA is coming out at around about 8, which is adequate size for implantation on QCA. As I say, it underestimates by about 30%, so it's around about 11 millimeters. It certainly looks by eye to be big enough. So we're going to go ahead. We start with the multi-purpose. We've obviously got these two valves to negotiate. I'm just going to go with the sheath. You can see the sheath and the multi-purpose. Get through the valves. It's a backwards and forwards rotation between finger and thumb. It is not a push. And often, actually, when you stop pushing, that's when the catheters spring forward. Obviously, the bigger sheath gives you a little bit more push. You just bring that slowly down. I'm just anti-clocking slightly And you can see that's now bringing us a little bit more aligned. The usual practice is to try and get the multi-purpose up as far as I can. Again, as I say, just rocking backwards and forwards. Know we've got to get through that valve. We're just watching the wire. As you say, sometimes pulling back, it can spring forward. It's not a push. You see that seems to advance quite nicely. I'd like to get right up there onto the bend. We're through the valve now. I'm just rotating the catheter backwards and forwards through my fingers. Good, so we're beyond that vertebra. So now we're going to leave the wire where it is, and we're going to take the multi-purpose out.
So this is the reducer device. One end it has 2 ports. One is the insufflation port, and this is the flush port for the central lumen, which we'll come back to. The first thing we will do, though, is prep the device end of things. So there are 2 components here. There is a protective cover of plastic that is over the device and the balloon itself, and there is a little metal rod that is distally supporting this portion of the device itself so that it doesn't get squashed or damaged. So the first thing to come out is the metal stylet, which is inside the inner lumen. It's a short stylet, about 6 centimeters or so. That comes out and has no further purpose, so you can pass that away. Then you gently get the cover off the device, being careful, obviously, not to dislodge the device. It's a relatively snug fit. And if you gently get that off, then we have the device ready to be introduced, essentially. You've got 3 markers on it, which you'll be able to see on fluoro as Steve delivers it. And the device is positioned between these 2 markers here, with its balloon extending a little bit further.
Good.
So then we will flush the inner lumen with heparinized saline. And now advance this over the wire. We will leave the side port, which will be used for the balloon itself, open to air for now. Unlike coronary stents, these tend not to be deployed with negative pressure, so we just leave them open for now.
So we're now going to load the reducer device and balloon on the back of the wire. So we give pain relief just before we're about to deploy. It can be a little bit uncomfortable as the reducer goes in. So we open up the O-ring maximally because we don't want to damage the reducer as it goes through. We'll just do that very gently. Good, we take an acquisition and we can see that there's a very faint outline between the bottom marker and the mid marker. You can see that the reducer is still sitting nicely between those two balloon markers. We haven't dislodged it or moved it. Now we're going to advance slowly. Again, everything in this procedure needs to be done slowly. Again, the stiffness of the balloon and the reducer can sometimes cause your catheter to come back, and that might need just to be advanced, but it seems to be going nicely at the moment. So now we're going to unsheath. Then we've got to get our waist around that body of that vertebra. And we're pretty good there if it stays put. So unsheathing. We're going back to the proximal marker.
So at this point, what Steve is doing is he's fixing the coronary sinus reducer and gently pulling back the guiding catheter. So this reducer does not advance, but it exposes the reducer as the catheter comes back.
Insufflator. We don't go negative on this. You can see we've got a 3-way tack. Well, we'll talk about that and the importance of that later. It needs to be off though. Good. So across the
valve.
Vertebra. Patrick's going to go up, just straight up, winding. We're going to start with 2 and then move to 4 because it's quite generous. So just keep topping it up. It's a very compliant balloon. 4 is, I'm doing to 5. It's top it up to 5. It's going to be up for a minute. Just going to acquire there. We're pretty good. We're right across that valve. Keep topping it up. Good, we're coming up to a minute now. There's some good inflation. We've got a nice waist. Fluoro, grab that, please. So now we come to the important bit, which is deflation and retraction of the device. So the first thing we're going to do is we're going to go negative on the end deflator. And we're just going to let this balloon, what I call burp. You're seeing some bubbles coming back. And we're basically dragging that contrast, you saw it there, dragging the contrast back into the end deflator. Again, this shouldn't be hurried. And we'll do this several times. We've got a three-way tap on here. We're going to close it to the balloon, empty the contents, and then go negative again. Still sucking back, so there's still some contrast. We're only using 10% contrast for this case. 20% is obviously thicker, more viscous, more difficult to remove from the balloon. So 10% gives you plenty, 10% gives you enough visualization to see the balloon inflated and should be easier to get the balloon down. So now we're going to retrieve. The 9 French device the 9 French delivery sheath shouldn't go through the waist of the device, but if it gets close and you're worried, then you push on the wire in order to take the sheath away from the waist so that it doesn't go through. What we're going to do is just very slowly, Patrick's going to keep his hands on the wire, we're very slowly just going to pull on the balloon, which should cause the catheter, the sheath, to walk in. And we're just going to do this in a very slow, continuous fashion. I can see the waist, we're away from it at the minute. And it's just slowly bringing that balloon into the catheter. Push on the wire. There we go. You saw it just release there. When it's in the catheter, that stored up tension often just lets the sheath relax and away from the waist of the device. Okay, so now we're going to take this out very slowly, watching the wire. We're fluorine all the way. You can see it coming back nicely now. Just, again, everything slowly, watching the catheter to make sure the catheter doesn't go into the device. Again, if it does, push on the wire and push the sheath back. Got the O-ring nice and open, so there we go, and it's free, so I've got that.
Multi-purpose.
And now we're going to take the multi-purpose. This is going to go through the waist of the device because we want to do a sinugram at the end just to confirm the position. My wire's trying to come out. I'm just going to push that on a little bit. Good. And we're going to do a sinugram. There we go. We've got some blood. We're going to take a picture. Nice. So you can see that the reducer is on the valve. We've got a nice oversizing in the proximal and the distal portions of the reducer. And it looks good. So now we're going to take the multi-purpose and the sheath back very slowly without the wire. The wire we don't want to use because the tip of the wire can sometimes latch onto the open cell design of the reducer. We don't want that. We're just going to gently slide everything back. Now we're in the right atrium. We're going to take another acquisition just to prove that it's still there, and you can see it waving at us nicely. So now we're going to take the equipment out, and we're going to press on the neck for 5 or 10 minutes just to get hemostasis at the end of the case. So we've taken the sheath out of the neck, and we're just compressing now, and compress for 5 or 10 minutes to get hemostasis in the cath lab, and the patient will return to the ward. She'll start aspirin and clopidogrel, and she'll take maintenance doses of these for 6 months until the device is endothelialized. Of course, we counsel patients that they won't have a full effect on their angina for up to 3 months. Endothelialization is required to fill in the gaps on the open cell design of this device so that it forms its hourglass shape and has its full hemodynamic impact. But of course, you would have seen today we landed on a valve, which was intentional. The leaflets of that valve will hopefully envelope around the waist of the device, and hopefully she might start to feel some improvement quicker than 3 months. So we had a lady with quite bad angina. She's on maximum medical therapy, and she had normal coronary arteries, but a big perfusion defect in the anterior wall. Perfect for coronary sinus reducer, which obviously will sit just in front of the great cardiac vein and should help her. We had straightforward access. It's a little bit tricky to get into the coronary sinus initially, but then we had a nice landing zone on a valve where we managed to pop the device waste on that valve, which hopefully it will start working straight away. Obviously, we counsel patients that it might take 3 months or so to get its full effect because it needs to endothelialize. If we land it on a valve, 2 benefits. 1, it can work quicker, and it's usually a much more stable position, doesn't tend to dislodge. Time will tell, but I think it's likely that she'll get benefit. We found in a handful of patients that we've used this in now for coronary microvascular disease that actually these patients really benefit. We believe that may be something to do with the mechanism of the device and how it works. These patients often have quite profound perfusion abnormalities, particularly in the subendocardial region, and we think that this device really helps improve the perfusion and re-establish the correct ratio of epicardial to endocardial blood flow. And in the patients that we've done so far, they don't get angina at all anymore. Usually we counsel them to say that it will get better, but they might still need their anti-anginal therapy.